gratis, for which we are very, very grateful. My name is Paul Hurley. Most of the time I moderate our forums, but tonight we're switching it up a little bit. One of the reasons is because of our subject, which is, the official title is OBGYN, having a baby in Tulare County. Any of you here planning to have a baby in Tulare County soon? I don't mean to pry or anything. But even if you're not, it's an issue for our community because communities need to grow, and we also need to have healthcare services for everyone that meets their needs. And right now, we're in a bit of a problem with services for healthcare services for women who intend to have a baby, are pregnant, are contemplating having children, or maybe have just had children. So that's what we're going to explore tonight, and we thank you very much for all being here. Pastor Dan Birchfield is not here tonight, couldn't join us, but if he were here, he would welcome you, and he would praise Tulare County Voices at 210 and everybody here, and especially me. And he would also say how delighted he is that you're all here and taking part of your evening out tonight to learn more about this issue. Now, that's going to be enough from me until the end. I'm going to turn this over to our moderator, journalist, businesswoman, mother, grandmother.
Long time ago. Grandmother, yeah.
Yeah, and an old friend of mine, and ours, a member of our planning team, Belinda Morales. Now, before you give her your applause on that, I'd like to acknowledge the other members of our planning team who are here tonight. Molly Melkonian is here. I know Donna Kinshu is back there you're not at the table. You're back in the back row. And Catherine Doe is here, right there. I know Lou Griswold is not here tonight, but he's also a member of our planning team, and I'm on that bunch too. And I'm always very grateful to them for the time that they take to put in to plan these programs for us and for you. Okay, now you can have a nice round of applause for Melinda Morales.
Are you going to introduce him? Okay.
Introduce them and get the applause for them.
Okay, so we'll introduce our panel to you now. Everybody can hear me, right? Okay, so starting on the left, Rita Barron is a certified nurse midwife with the Visalia Women's Specialty Medical Group. And in this community, no? Kauea, okay. Off and running, aren't we? Okay, okay. Okay. And so I'll go through and introduce, and then each of you has a microphone, so anytime that you're having anything to say to the audience, please use your microphone. So my apologies for that flub in the beginning. Next to her is Ryan Gates, and if I don't get this wrong, then I can't read. Chief Ambulatory Medical Officer for Kauea Health. Okay, did I get that right? All right. And then Dana Holmes, who's the director of the Care Pregnancy Resource Center in Visalia. There are 2 Care Pregnancy Resource Centers in the county, one in Visalia, one in Tulare. So please welcome our panelists. Okay, so we've had quite a discussion leading up into this topic tonight as we planned it, because we've been hearing more and more and becoming more and more concerned about the state of what young women, young mothers are facing when they find themselves pregnant in Tulare County. And with the pause and then closure of birthing services in Tulare and some other changes in the county, it's a problem. It's a real problem. Now, it doesn't affect me, but there are women out there that this is a serious problem. And sometimes I wonder, how do they get started? Where do they go to find a provider and then a hospital to meet their needs? So that's the core issue and core question tonight is, what's our situation? What are young women and young mothers facing? And what is being done? What is our community doing? What are the services that are out there? what needs to change, that type of thing. And of course, we have some questions, and then we'll have some questions from y'all as well as the evening progresses. So we'll start with what's the situation now? Where are we in terms of providers, services? A young woman finds herself pregnant, happy day. Does she become very sad when she goes to find a provider and a place to deliver? We'll start with Rita. Take your microphone. Actually, if you can hold it, you might be more comfortable. Yeah.
It's a real problem. And
Is it on? Is it green? It's on. You just hold it to your mouth.
oh, all right. So, all right. No, I'm more comfortable standing. All right. So anyway, there is a huge problem, and I see patients every day that it's taken forever to find someone to take care of them. I have women that have gone through half of their pregnancy without any care because they can't get in. Unfortunately, there are only so many providers here, and we can't take everyone there is. They're having to go to Bakersfield, they're having to go to Fresno, they're having to go to Clovis, they're having to go to Hanford, they're reaching out all over. Some were going to Porterville, and then that sort of, they lost their providers also. So it's a serious problem, and a lot of the women are very, very worried about their care, about themselves, and about their babies.
Before we move on, what percentage would you say is leaving the county in search of services?
That I'm not sure.
Okay, then let's go on then to Ryan Gates.
Thanks for having me, by the way.
I think you need to hold your microphone as well. Sorry, guys.
No problem. Happy to hold it closer. Sadly, we are in good company across the United States. 2010 to 2022, I have it here, 537 hospitals in the United States closed their OB services. There's about 5,000, so that's more than 10% of the hospitals in the United States have closed OB services. So we're not closing our OB services, by the way. We have 14 OBs very active delivering babies in the hospital. We have Rita Katie Finks is another nurse midwife, very seasoned and experienced delivering babies. And so we have 24/7, 365 OB in the house. So we are not closing. We're not, no closure imminent or anything like that. So we do, however, have a very unfortunate convergence of several issues in the last 12 months that has really exacerbated the problem and the shortage, simply to Rita's point, of OB access in the community, be it nurse midwives or OB physicians. Our highest priority at Kuya Health right now is OB. I have, in the last 14 days, interviewed probably 8 OB physicians, have made very aggressive offers, of which every time we offer, they are very, impressed with what we're offering to recruit them here. It is within fair market value range. I have my board of directors over here. So we're compliant with it, but because there is very strict compensation rules for hospitals and physicians, but we are within those, but certainly aggressively recruiting and pursuing more access. If you were to, and I think you would agree, yes, outpatient access, establishing care, getting that prenatal services is crucial. But what is the highest priority is a mom walks into our hospital in active labor to have an OB in-house to deliver. And so we are, with the dwindling supply of OBs, A, in the community, B, in the community and willing to take restricted call. Not all of our OBs in the community, through work-life balance, want to take restricted call and be in the hospital. So our highest priority is to have our hospital, have an OB physician in the hospital. If they're in the hospital, they're not in a clinic. If they're not in a clinic, they can't establish care. And all of our OBs that staff our current laborers group today all have outpatient clinic time. So none of them have abandoned their clinic time to come in to be laborious. They all share the schedule. They give up their clinic day to be in the hospital. But they're having to do more of that, which then further exacerbates outpatient access to established perinatal care. So, yes.
Okay,
I'm sorry. Yeah, hospital verbiage. So there's two types of call in a hospital. One.
Could you repeat that question?
Yes, thank you. Yes, I will. Yeah, I was asked what does restricted call mean, and I'm sorry. Stop me, hold the line just like that. If I say an acronym or some hospital gobbledygook that you don't understand, I'm happy to explain it. So there's two types of being on call to a hospital. One is called restricted call, meaning that we are paying a physician to be in the hospital on the premises. And so that's restricted. You are restricted. You can't work in a clinic and then get a call and run to the hospital. You need to be in the hospital. So that's restricted. Unrestricted call, meaning you're not restricted to be on the premises. You can be in the clinic, but you're on call. And so if a patient shows up and needs help, we're going to call you. You need to be at the hospital within 30 minutes. So that's unrestricted versus restricted call. Thank you for that clarifying question. So I'll pause there because I can obviously talk.
Yes.
Longer.
Okay. Thank you.
I'm not known for my brevity.
So yeah, let's let Dana now say what are you seeing? What are you seeing these days? What's the situation in your area?
Right. So Care Pregnancy Center or Care Pregnancy Centers of Tulare County, we have been in existence for about 40 years, and so we've been primarily our clients have been those that are facing unplanned pregnancy. Most of the time, they immediately want to be or need to be connected to a conversation about their pregnancy, or have a medical grade pregnancy test, an ultrasound, things like that. So primarily, we have been serving in this area for quite some time. But what we've noticed lately, within the last 12 months, we'll talk about, our numbers have actually doubled, and they're actually in the range of tripling now for the clients that we're receiving who need those first trimester services. So what we're hearing from our clients is changing up a bit from what we typically hear. Most of our clients come in and they're within that first trimester, within the first few weeks even of their pregnancy, very early on. And now what we're seeing is clients that are further along in their pregnancy that are coming in that are having trouble connecting to an OB for whatever reason, whether it's geographical location that they're in, maybe they're on the outskirts of the county, maybe they tried to connect with an OB at a time when it was a surge in that clinic. So what we're doing is we're actually there for our typical clients who come in looking for those first trimester services, but what we're doing is we are serving anyone who comes as much as we can within the scope of our services. So we're noticing heavier traffic further along in their pregnancy, definitely more desperate for services, more anxious about services and about not being seen as quickly as they feel they need to be seen. Of course, these are a variety and varied circumstances, right? Each pregnancy is different. Each pregnancy has its own risk factors. But we are seeing more women that are desperate to connect with OB services that are a little bit anxious about the fact that they're being seen later. So that's what we're seeing now.
Okay, so I think Ryan, you had said you have 14 OBs. Is that right?
Yeah, I looked at the call schedule and the deliveries, and there was 14 OBs that I know of actually.
And how does this compare? How does that compare to, I don't know, pick a year, last year, 5 years ago, 10 years ago?
Yeah, I don't know. Rita might be able to give a better, finer point on this, but I know, Family Health Network, for instance, probably 5 years ago had 8 OBs. Today they have 2. And then we have Visalia OB, so Wiseman, Boken, Bosman, and then Quinn. Now there's only Quinn. So So there's 3.
Okay.
So that's 9 I can count in just a brief. And there's others, retirements and other OBs who have
So
retired,
from what we can been able to gather, the changes have been rather sudden. Like there's been a dramatic
Correct.
change in the last year. Can each of you outline for me where this is coming from? The what you would say this is why it's happening? Rita, can we start with you?
It's hard to say why it's happening, except that
A little closer.
the staff that is left, the OBs that are left, are really overworked. And so a lot of them have left, or they have restricted how many patients they will take, because you can only see so many and do well with so many. And then if you get an overload, there's an increased risk of having problems or not doing the right thing for the patient that you have. And so because of that, we are restricting how many we see. Like right now, family health care is not taking any new OBs at all. And Altura, who's in Tulare, who delivers at our hospital, are restricting so many per provider per month. And we are taking all we can take, but we have limits also. There's 3 physicians, 3 OBGYNs that work with Kauai Delta and myself. And again, we're seeing an overload, and we can't do that all with the providers we have.
Ryan?
Melinda, can I ask a quick question apropos
Sure.
to what you? So, if a pregnant woman a newly pregnant woman comes into Family Health Care Network, what happens?
I'm not as intimately knowledgeable about Family Health Network operations. I was rounding on Mother Baby today, and I actually talked to a new mom whose Family Healthcare Network lives in Visalia, but they assigned her to the Porterville office, and so she was going to Porterville to have OB services. And I don't know if that was with a midwife or an OB physician. I know they also have a family medicine physician with OB scope as well. So I know that she was assigned to go to Porterville to access care, because I think Bencomo and others.
Which
were
is a long way away.
Which is, and so she went into active labor yesterday, and she's like, I'm not going to make it to Sierra View, and so she came and delivered at Kauai. And God bless Dr. Bencomo. He came in from Family Health Network and delivered her, and he wasn't even on call, but I'm assuming he left his clinic practice to come in and help deliver, and then ran back to clinic. And
Okay, so let's go back to another number. How many? Okay, we're sending women away, and we're expecting someone else to pick up the slack. But what's the numbers here? How many babies are being born here, and how's that changed again over time? Ryan.
Yeah, a question was asked earlier. What's the sense of leakage or moms leaving the area versus coming to Kauai? I'll tell you, we know anecdotally it's happening. It's a little early with medical claim data. It's usually a 90 to 120 day time lag, and so this is a relatively recent phenomenon of lack of access. But we know it's happening. However, I will say that because of the closure of Tulare OB services, because of the restriction at Sierra View, they're really hurting for OBs as well. They don't have the coverage that we have. And Family Healthcare Network, earlier in the year, I'm not sure if you're aware of this, but they used to also deliver babies at Hanford Adventist, and they made a move last fall. They are no longer delivering any of their babies at Hanford. They're bringing them all to Kauai. So Kauai is standing this year to have the highest number of deliveries we've ever had. Over 5,000 is predicted to be delivered at Kauai before the end of this fiscal year.
So how many babies are actually being born here at Kauai?
Over 400 a month. So we're on pace to be over 5,000 deliveries in this fiscal year at Kauai. So we're not seeing a decrease of deliveries at Kauai.
And how about for county? Do you know the county numbers?
I know our birth rate
Okay.
relative to California And if you've read recently, California out of 50 states had the lowest birth rate of any of the 50 states in the United States this year. California birth rate is 53.8 per 1,000. Tulare County is 68.2 per 1,000, which is the 6th highest out of 58 counties in California. And right next door to our west, Kings County is 71.7 births per 1,000, which is the 4th highest birth rate in California. So the Central Valley, we're picking up the slack when it comes to, maintaining the human race, I guess. And so we have a healthier birth rate than the average in the state of California.
Okay, so we've lost providers. What are some of the other contributing factors? Why are to women not being able to get the care they need? You said fewer providers. We're obviously lost a birthing center in Tulare because of fewer providers, and maybe some other reasons. What are some of the other contributing factors to our situation right now?
I mean, I really, not to overcomplicate it, it is the lack of access. It's
Okay,
a lack of
okay.
access to maternal health providers, be it OB-GYN physicians or certified nurse midwives. And so I think that's the nexus of the problem. And so then it's like, well, why? Where are they going? Why are they leaving? With over 500 hospitals closing OB services, where are these OB physicians going if they are closed that hospital,
exactly.
right?
Yeah.
And so you have the baby boom generation retiring. So that's probably the biggest piece of the equation, is you have a lot of the physician force retiring, and you're not having enough supply coming in behind them to replace them. So that's one. As it relates to another factor in that is the new generation of physician. We recruited both Holly Quinn and Carlos Rangel, amazing physicians locally. Holly went to Redwood High School, went off to medical school, and she's come home. Carlos Rangel went to Tulare Western High School, went to Harvard undergrad, or MIT, Harvard Medical School, UCLA residency, and came home. So he is an amazing physician, probably the most impressive academic pedigree we have on medical staff, I think. But they're both young parents. Holly, just had a baby last year, and she wanted to be a little bit of a mom. And I don't want to take call every night, and I want to spend time with my baby and my husband. And so the new generation of physician is just cut from a different cloth. And I have 5 children and a wife, and I hold in very high view the seasons of life. And Holly was ready to leave the community because she was looking for a place where she can kind of back off a little bit, not have to take call. And so we accommodated that. We created a place where she can stay in the community in the season of her life, continue to provide care, but to have some balance. But that balance means less. I don't have a physician I can put on call, right? Okay, just want to keep you. Carlos, same. I'll come, but I've been in LA for 5 years. My wife just had our second child. We want to come home. And I don't want to do call on weekends or every night. And so we made accommodations to bring them in, recruit them in.
So are you
They're
finding
very happy in their practices, but it's a...
Are you finding more and more that you need to make accommodations for? Because I assume, I'm going to make an assumption here. I know there are several residency programs here. Are we training OBs?
The
No?
closest OB residency program we have is UCSF Fresno and Kern Medical in Bakersfield. When we started the GME program here over 10 years ago at Kauia, OB was on the list, I understand, but we just didn't have enough of the local support to be faculty to start that program. And I wasn't here at the genesis of it, but that's my understanding. So no, we don't have OB residency training here.
Okay. So go ahead. Yeah, if you have a question, Catherine will come around with the microphone. How's that?
I just wanted to clarify with the Hanford thing. I don't know if everybody, the Hanford
Closer to your mouth.
Hanford is still delivering babies.
Correct.
It's just that they lost one of the providers. But
Yeah.
Adventist still delivers babies.
Yeah, I'm sorry. Thank you for the clarification.
Yeah.
Yes, Adventist Hanford is still delivering babies.
A lot of babies.
A lot of babies.
Yeah.
Family Healthcare Network, however, the second largest FQHC in the United States, is no longer having their patients delivered at Hanford, which is
There.
a significant volume, and
Right.
they're steering them here. And so that's
Right.
why our volumes have, Family Health Network, I think, is over 30% of our deliveries of their patients. They're a very, very large clinic system. They didn't have enough OBs to provide the call coverage in multiple hospitals. So they said, we're losing OBs. We can only provide call coverage to one hospital instead of 2 or 3. So we're going to consolidate our OBs at Kauai and have all of our patients come to Kauai for delivery, because that's the only place that we can staff it from a OB perspective for deliveries.
So they're
I had
sending
a
everybody here?
I had a question for Dana. If you don't. So do you try to connect you meet a lot of newly pregnant women, and have you had any success in connecting them with OBGYNs, or is that not part of your services? And then the follow-up, do you find that challenging, like they decide to terminate because they're like, okay, there's nobody out there to help me? How do you deal with that?
Is that the case? Is that the situation?
Well, if you don't have a doctor.
So it is a contributing factor, we believe, in women feeling like they will be supported. So the majority of women there's definitely, someone corrected me the other day, a lot of pregnancies are unplanned. So when I say unplanned pregnancy, it's kind of like this broad brush. A lot of people are surprised by the fact that they are pregnant. We mostly see women now who their top concern is OB care. Yes, this has changed over the past 12 months. We do connect them to OBs, and our list of resources and of recommendations has shrunk over time. So our nurse manager and sonographer has modified the list over and over again. But I will say that to kind of shed a positive light on all of this just a little bit is that the women that are coming to us are incredibly resilient people. They're incredibly resilient moms. The majority of people that I meet through this process and through my staff and just the women that come in, these women, they see life, and the majority of them want to have babies. We do have that narrow margin of people that come into that they just don't have support. So they have doubts and fears that lead them to think they should terminate a pregnancy. Absolutely. Is it part of the equation? We believe it is. Because what we do at Care Pregnancy is we help them to hear their own voice, for one, and to sit in a room and just kind of think about what it is that what decision they're making, who it affects. If they can see life in their decision, this is positive for us, absolutely. But what we're seeing is women that are more anxious over time about what continued support, medical support will look like. So just the level that we're dealing with, the poverty level, the support level, all of it contributes. So the lack of OB services in our community is concerning for us, even though we love meeting women and we love expanding our scope of services. At the same time, we really understand the heart of our community is to support one another. So when we have a lack of services and we kind of feel like, oh, what can we can't do anything. That's when we start connecting. And I've already spoken to Rita and Ryan previously. We've already had conversations. They have been incredibly supportive. Kauai Health is doing a fantastic job. They are working so hard. And Rita is really just pretty much a icon in our community. So I feel like it's a privilege to sit with them and have these discussions. But they're so willing to hear and to listen to my concerns as a local resource. But we want to encourage every community member to come around and ask questions. And we may be more available than Rita and Ryan are right now, I can imagine. But we're here to support women and men and families in our community. And if we have trouble connecting to an OB, we don't really leave a stone unturned. I have connections with other directors of pregnancy centers throughout these 5 counties that are the highest birth rate in California. We're all brainstorming, we're all working together, we're all trying to connect with OBs as needed and to expand that list of OB references that we can refer people to. So I know that there's a lot of people working really hard on the solutions to come. But I can tell you that women in this community, the majority of them want to have babies and healthy families, and that's the thing that keeps us going.
I'd like to learn a little bit more about the relationship between doctors, OBs, and hospitals. Can you explain, I guess, Ryan, how that works? And is there an issue between OBs and hospitals?
We start every morning singing "Kumbaya" together, and it's it's a beautiful thing. No, it is a partnership. So California is a little challenged. For those who don't know, but in the state of California, hospitals are not allowed to employ physicians. So we have to contract with physicians for services. A lot of physicians, matter of fact, a lot of the OB physicians want to be employed. I'm recruiting OBs from other states. They're employed by the hospital. And recruiting physicians from federally qualified health centers. They're employed. They want W-2 benefits. They want to know they have to take some vacation time and their malpractice is covered. And so that's something that CWIA has been working very hard on. There are ways to provide what physicians are looking for in employment, and we're putting those together. It's a constant collaboration when it comes to physicians and how to support their practices. I think, again, Holly Quinn and Dr. Carlos Rangel are two great examples of OBs that we have added to CWIA Health system in the last couple of years. Both came from employment environments. They're both now contracted because we couldn't employ them. They were a little nervous about that, like, what's that going to look like? I don't know how that works, and I don't really do billing, and I don't want to do billing, and we'll do all that for you. And we're able to really just help them be physicians and not have to be a business administrator as well. And that's something we really strive to do. And I think we've been doing a good job. Holly and Carlos seem to be very, very happy with their, Rita's got more of an inside scoop because she works with them directly in the clinic every day. So that's one aspect. But we also partner with, Family Healthcare Network, or Altura, where those physicians in those clinics, seek privileging and credentialing with CWIA. And so our physician medical staff screen and vet physicians, and at times exclude them or don't grant them privileges if they don't have, if they're not a strong clinician. We take responsibility for our community to make sure that the physicians who are working in the hospital are quality, and our physician medical staff kind of governs that process as well.
I think we have 3 questions.
Oh, goodness.
So relevant to what you're saying,
Okay.
I'm guessing.
Yes, this may be a very naive question, but I'm wondering why in the state of California only are hospitals not permitted to employ doctors?
Yeah, and we're not the only state, but there, a lot of states do allow employment. The corporate practice of medicine, the legislators felt that if hospitals employed physicians, they could put pressure on them to not provide good care for the sake of money or savings or whatever. And so they felt years ago that physicians in hospital should be separate to not afford any conflict of interest potentially. I think it's an antiquated law. There's other assembly bills coming that come and to overturn that. I think a lot of states have overturned the Corporate Practice of Medicine Acts in their states and allow employment. So, but that's the intent behind it, is to protect the medical conscience of physicians.
Go ahead.
Quick question. So we've seen the rise in nurse practitioners. Are there nurse practitioners in the OBGYN space?
Yes, there are mid-levels. Unfortunately, we've been sort of working on getting a midwifery group going for several years, and it comes and goes. We have had midwives in and out, but never where we could build a practice. And in the larger areas, they do have midwifery services. They're on 24/7, and the reason they're so helpful is because they will take first call And then we only have to have one physician in-house or available for backup. And we can deliver all the routine patients, and they just come in for high risk or cesarean sections, and that helps immensely. But to get a group of midwives, you need a minimum of 4 and more likely 7, and we have never gotten to that number. And they've been employed by different groups, and so they haven't been able to really join and become a practice. Kauai has worked on this and worked on this and worked on this. And unfortunately, it hasn't occurred. And now, unfortunately for me, I'm old, but the midwives that are coming out of into practices, which Ryan had said the same thing about the physicians. They are trained in a different manner. They don't take 24 hours, 7 days a week call. I mean, I'm used to that, but they take a 24-hour shift once a week, or they take two 12 hours on different days. They work a couple of days in the office, and that's that. And that really decreases the amount of patients and the amount of availability. And that's why a lot of them don't want to come here, because they like being in a big center.
Has anybody approached Fresno Pacific about expanding their program to include OBGYN? And can nurse practitioner OBGYN see patients in a clinic?
They can see patients in the clinic. They cannot do hospital-based work. They cannot do deliveries. They cannot admit patients or discharge or see them after delivery or during delivery.
In the OB space, it's really all about the nurse
Yeah.
midwives as the advanced practice provider. We do have a nurse practitioner in the outpatient OB-GYN space, and they really help with, the routine clinic visits to help free up access to the OBs and the midwives as well. But to Rita's point, their access or their scope is restricted to the outpatient clinic setting.
And then you mentioned about Hanford, that Hanford is still delivering but has no OBs.
I'm sorry. Yeah, they do. No. And I really don't want to misrepresent other organizations, so I apologize. It is strictly related to Family Healthcare Network. So that clinic system is no longer having their patients go to any other hospital other than Kauai to deliver their babies.
Okay.
But ARIA, the other private practice physicians, Adventist Health has a gigantic rural health clinic system. All those moms go to Adventist, or they can go to Adventist. They routinely deliver every day.
Okay, so they're
So-
not delivering without OBs.
No. No,
Okay.
they have OBs. Yeah, sorry, I do not want to
Okay, so
misrepresent.
what you're saying then about the newer physicians that are emerging from training, they want a different life. They don't want the life that Rita had. and I guess that's not difficult to understand, but that means that the whole model has to change. What's got to change? And if we want to give these people a reasonable life, I mean, nobody wants to do this 24/7, but what has to change in terms of the training, the education, what?
I think that what Ryan said is what is going to make it happen, and he is willing to compromise that 24/7 in order to keep physicians in the area. Like he said, Holly Quinn and Dr. Rangel, they're great. They're wonderful. They have kids. They got to spend some time with kids. And we were trained that you just work, and we all became workaholics. But they are not trained that way, and it's probably more appropriate the way they're trained than we were.
Right. Yeah. I couldn't have asked for a better lead-in, I think, to what I'd like to share with you. You're right. It needs to be a new model. And part of that is setting expectations with your patients. Because moms are used to, old school, all 5 of my kids were delivered by Dr. Finberg in Bakersfield. And he was at every single delivery, and I don't know how he did it, but he did it. And he was in solo practice, had his own office by himself. I know he worked with a couple other OBs to help him out on his vacations, but other than that, it was him. And so the expectation is more team-based care. And I'll tell you, part of what we are trying to bring to the community immediately, because we are in an immediate crisis, right? We're in an immediate shortage. And we have not stopped recruiting OB since I've been here, and I've been here for 10 years. And so trying to get OBs to come to the community is a challenge. So there's a group called OB Hospitalist Group, OBHG, is the largest OB-GYN medical group in the nation. Over 2,000 employed OB-GYN physicians. And I would say over in the world, therefore, because the United States has got a lot of physicians, and they staff over 300 hospitals in 39 states. Dr. Carlos Rangel, who's with us, worked at Providence, LA with OBHG, speaks very highly of them. Katie Finks worked at Little Hospital of Mary in LA with OBHG, spoke very highly of them. We have been talking to them since January. We've contracted with them, and we've got on-site visits, and they are able to just draw from an immense pool of vetted, licensed, quality physicians and bring them to Kauai. They focus on one thing: inpatient OB care. So they don't compete with local OBs. They don't do outpatient. They don't establish care. They staff the hospital for unassigned moms or with OBs in the community, for instance, who, I want to deliver my babies, but I don't want to be on call every day. And so OBs can say, okay, OB hospitalist group, you can deliver, my babies, or on these days, I'm not going to be around, so I'm reassigning any mom that shows up in imminent delivery to you all. And so as a hospital, we are looking to fund and bring that model here locally, to bring in OB hospitalists in the hospital so that it can back up our OBs in the community, like Holly Quinn and Dr. Rangel, who know they have an OB in the house that they trust, and they could tell their patients, like, look, I'm going to strive to deliver you, but I might not be the one, but I've got a team of physicians that are there, and they're great. And so setting expectations, forecasting that up front, and we do a lot of that today. I mean, our OBs back each other, and Rita as well. But that's the new model of care.
And so how far away are we from that?
Well, actually, we were going to go live this week with that. But we talked to our local OBs. So we have 5 OBs that again, provide our laborist services in-house. They gave us notice in December, a 90-day notice, like, we just can't keep this pace anymore. We're going to terminate the contract. And so starting March 10th, you all need to figure out something else. And so we obviously, as a hospital, highest priority, started talking to OBHG, okay, we're going to bring physicians in. And we had some, where that meant a time frame. I mean, you're really just bringing in locums and just staffing. And our OB said, look, we'll give more time. So they extended their commitment to staff our hospital to give us more time to make sure we're bringing in quality physicians as we're recruiting them. So God bless Dr. Banks, Beatree, Sabagal, Vicente, and the 5th one, sorry, Kadimi. Those 5 OB physicians are servants to this community, and they are sacrificing a lot of their own time at home to be on restricted call in the hospital, just those 5. And they're holding down the fort for us while we're trying to bring resources to help them, yes.
We have a
Go ahead.
we have a litigious society,
Yes.
and you mentioned malpractice. Is OB work particularly risky, and what challenges does a doctor face as far as covering that expense?
Yes, OB is probably the highest malpractice specialty you can have. The state of California, fortunately or unfortunately, depending on your perspective, has some limits, and so malpractice insurance for OBs in California is not like some other states where physicians are literally leaving other states because they simply can't afford to pay the malpractice insurance. But I mean, to Rita's point too, for a physician to back a midwife, it increases their malpractice because now they're assuming some liability to back midwives as well. And so that's been some of the logistical challenges of developing a midwife program to have all the OBs agree to spend another $5,000 a year or whatever to add malpractice coverage for midwives to their on the off chance that Rita might need a C-section backup, right? The hospital's willing to pay that as a pass-through to whatever increased cost to the physicians, but and that's something we've done with our OBs who are willing to back Rita.
Can they band together? Is there a benefit?
So when they join into larger medical groups, you can have some pooled, but malpractice is really very physician specific as it relates to how many malpractice cases you have had. The more that you have as an individual physician, the more your premiums can go up.
You have a question over there?
Let's get the mic. We're streaming, so I want to make sure everybody.
So you've talked about increased expenses in labor, and then you've talked about increased expenses in insurance and things of that nature. So then the flip side is, are you getting enough in reimbursements to cover your expenses? So that way, a year from now, it's like, oh no, we're head over heels in debt, and we got to shut everything back down.
Right. No, so that's a great question. Thank you for that compassionate perspective. As it relates to women's health services, fortunately, the federal and state governments see the shortage, and they have put in some enhanced reimbursement, particularly for the Medicaid or Medi-Cal patients. And so long as Dr. Oz and Doge, don't claw back a lot of those enhanced payments for those patient populations, I think we're going to be okay in terms of what CAWIA is willing to invest to bring these physicians locally to shore up the shortage. So long as everything stays the way it is today, and again, these enhancements started January 1st, 2025. So these are relatively new and in perfect timing to give us the confidence to be able to put out this amount of capital to bring physicians here.
What about medical school graduation rates? My understanding is that the shortage of MDs in our country is about 5 times the annual graduation rate. Is any? Huh? Sure.
Hello, everyone. I'm Dean Levisan. I'm a former OB in this community. I practiced OB for 34 years. I've lived about 6,000 babies. Nothing compared to Rita, but I've seen a lot. Just for some historical perspective, when I came to Visay in 1982, CAWIA Health had about 1,600 deliveries a year, which is, I guess, about less than a third of what you're having now. Also, when we built in 1992, when we built the current maternity unit, that was designed with looking into the future of someday having a maximum of 3,000 deliveries. And you're now doing 5,000 deliveries in that facility. Also, when I came here, there were 7 hospitals delivering babies. There are now 2. And when I came here, I think there were probably at least as many, if not more, OBs delivering babies in Tulare County than there are now. Part of that problem to address, I want to just make a quick comment for this gentleman who asked about the liability insurance. When I gave up the obstetric portion of my practice and just practiced gynecology, my liability insurance premium went down by 75%. Delivering obstetric care is very expensive in terms of insurance. In terms of your question regarding training of OBs, it's not really the medical schools, but the residency programs that turn out the obstetricians. A young doctor goes to medical school, graduates as a physician, but then they take specialty training. I took specialty training as an obstetrician gynecologist, which was 4 additional years of training beyond medical school. That's average for residency. Some are more, some are less. The choke point for OBs in this country is the number of obstetricians who are being turned out from residency programs each year. That's the number of obstetricians that are produced by our medical schools and residencies each year. That number has not changed much over the years. Probably 15 years ago, there were as a number, 1,500 residency slots in the United States, which means that each year, after 4 years, there were 1,500 residents turned out. That has increased slightly to 1,600 residency slots. But there's another factor that actually has decreased the number of practicing OBGYNs, and that is subspecialization. I think I mentioned that I was a specialist, but there's training beyond that. There are some OBs, and this is in many fields now, you can become a subspecialist. What that means is that there's an additional narrow space for you in the practice of medicine. As an example, in OB, there are several subspecialties. One is the practice of high-risk obstetrics. The other is reproductive medicine, infertility. The other is gynecologic oncology. Those subspecialists only take care of women with GYN-related cancers. And then there's a newer subspecialty called urogynecology, which relates to women who have urologic problems, oftentimes related to childbirth or just as they get older. The importance of this is that when I finished my training in 1982, 5% of those 1,500 graduating residents went into subspecialties. Now, it's at least 25% going to subspecialties. And where that relates to this problem is none of these subspecialists deliver babies. That may be why they go into subspecialties, I don't know. But even high-risk obstetrics doctors do not deliver babies. Reproductive endocrinology patients, infertility doctors don't deliver babies. Gynecologic oncology don't deliver babies, and urogynecologists don't deliver babies. So the effective number of OBs who are being trained each year who will deliver babies has decreased. When you combine that with the lifestyle expectations, there, in terms of full-time equivalent OBs, there are probably many fewer than when I trained.
Wow.
Thanks for that, ray of
That was
sunshine.
illuminating.
I should just scoot over or trade seats with Dr. Levitan for sure.
Yeah. Okay. So, wow. Hadn't thought of that. Oh, go ahead. Yeah.
Hi, this question is for everyone. How important is it for a mom to get OB care during the first trimester? And then there's another question that I have. I had a high-risk pregnancy, so anytime I'm pregnant again, I have to get OB care where they're going to give me steroid shots so that I won't deliver early. What are high-risk pregnant moms going to do now that they can't get regular OB care? Are they going to come to the emergency room every time they need their shots? How is that going to work?
Okay, that sounds like a Dana question, right?
Actually, I think that's a medical question. However, the part of the question about how important it is, I think obviously it's important to everyone in this room or you wouldn't be here right now. And the first trimester being so critical to women and their mental health. We haven't really talked about the mental health piece here that affects women who have miscarriages or who have high-risk pregnancies or some kind of pregnancy-related trauma. So I think that's a very good question. I think that we are working together, I feel like, in a way that we haven't before with partnering up with the medical community and midwives and nurse practitioners and trying to come around and surround that one woman, the one woman that we can see, the one woman we can talk to, and calm her fears maybe with a pregnancy test or an ultrasound in that first trimester. That's our part at Care Pregnancy. That's the part that we can focus on and the part that we can help with. And I believe we have been helping in this time when women need to be seen. It's what Mr. Gates said is that it's important right now. Like we have a crisis right now. If we're having women find us and come to us who have never come to us before, and the numbers that we're seeing are numbers we've never seen before. The stories we're hearing we haven't heard before. There's something going on. So what we do at Care Pregnancy is we try to meet them right away and get them help right away in any area we can help with within our scope, or we try to find them help that they need locally with the help of other people in that. But I think that is a medical question, definitely for Rita or for Mr.
Rita, what
Gates
can you add to that?
Well,
As we know, a lot of women have to establish that they are pregnant. How far along are they? There's some that come in way more advanced than they thought they were. And also there's the miscarriage rate. And, you know, they sort of blame themselves. I didn't get care. Something was wrong. I should have done this. I should have done that. And they have to live with that. And it's very difficult to, you know, for them to say, well, you know, I did the best I can do, and that just happened. They are very concerned about getting care and knowing that their baby's okay. And especially women that have had miscarriages before, they're very anxious to get in and to be seen and to be established so that they know that they are doing the best thing they can to keep that from occurring.
So what's the best thing we can tell women today when they find themselves pregnant? What's the first step for them? If it's difficult enough to find a provider, what do we tell them to do first? Where do they start?
Well, practically, so the outside of Family Health Network, as we talked about, the largest women's health or largest pool of OB-GYN physicians in our county is with Altura Health Centers, based in Tulare. They have clinics in the community elsewhere, but they have 6 OB-GYN physicians there, 7 if you count Dr. Saria, or Dr. Saria's wife only does GYN, but so 6.5 physicians. And then we have 3, and so there's 9 between Kauai Health and Altura. Our call center, so when the access crisis started hitting a fever pitch here in September, August, we were getting inundated with calls. Our call center was, and so was Altura, but they had more access than we did. And so I talked to Graciela Soto, who is the CEO of Altura, a wonderful lady, very collaborative with Kauai. And she got our call center, and we got our call centers together, and our call centers are connecting patients. Oh, you live in Tulare? Let me connect you with Altura. Or, hey, you live out in Exeter? Let me connect you with Kauai. Altura has also, Graciela has also contracted with commercial insurances that they weren't contracted with before, just so that they can accept more moms, because sometimes your insurance limits who's in your network, right? And so they have really worked to open up their OBs to the network in terms of health insurance plans. So a wonderful collaboration between our OBs and our organizations to try and meet the needs of our community in that regard. I will say we do partner also with Valley Children's MFM physicians, and so they have and we help fund that clinic that Valley Children's staffs over there on Acres that has MFM specialists that help run alongside our OB physicians for high-risk pregnancies. And so that's another point of access for high-risk moms that need those steroid injections or what have you, is to have an MFM physician that really runs shotgun with the OB to help manage the high-risk conditions of those moms through delivery. And then, of course, Valley Children's neonatologists staff our hospital in case there's a NICU need or what have you. And so we do have wonderful collaboration with community-based organizations like Altura and Valley Children's to bring as many resources to bear locally that we can. To Rita's point, it is a challenge, and we do, and we also, not to get on super much of a side tangent, but GYN access, you know, that's also an issue. But when we are trying to do what the best by our community for the priorities before us, it's establishing care with moms. Not that OB-GYN stuff can wait, because, you know, ovarian cancer doesn't want to wait either. So we know that is an important access point for us, but we are really trying to prioritize the access to OB physicians for newly established moms, and we're working with other, you know, clinic systems to have expand that access to. So that's
quick question.
Where?
So if a woman comes and says, I'm pregnant, and they're confirmed to be pregnant, how long before they get their first ultrasound and maybe go all the way across the board?
That's really hard to say. It just depends on, I mean, I have some patients that have to wait 4 weeks to get in. I have some that I, know about, or they've gone through ER or whatever, and we get them in as soon as we can. There's no way for us to do. I mean, we do the best we can do. And sometimes it isn't the best as far as the patient's concerned, but we only have so many openings and so many visits and so much time. I mean, I'm there a lot, and so are the doctors, and we do the best we can do under the circumstances. That's all I can say, is we try to get them in as soon as we can, but not always can we.
Okay, so in hang on one second, listening to the discussion about collaboration, I mean, it does obviously sound like something that everybody has to work together to get women where they need to be seen. So in my head, I'm picturing this team of healthcare officials and people in this county who are sitting down and working together to figure out how do we fix this problem? How long can this go on? So what is the solution? Who's responsible for creating the long-term solution for this current situation?
I'd like to answer that last question if I can, just again to shine a little hope. So we're a couple of small centers at this point in time, but we do plan on growing. We do plan on growing. We are growing organically. We're just trying to keep up with the need, with the pace of the clients that are coming to us, that the patients are finding us. So to answer that question, we actually can do an ultrasound as soon as we can verify her medical history and that she is sound to have an ultrasound, and our standing orders now are 6 weeks. So as long as she meets the criteria, we can do an ultrasound that day if needed. So that's the great thing about having a pregnancy resource center with care clinic connected to it in your own community. We can do those ultrasounds that are needed. We can do the written pregnancy verification that they may need to get resources somewhere else like WIC or other services that they need to sign up for. So we are basically there for the immediate need. We want to serve them as quickly and as well as we possibly can, and do that in a medical sound way. And actually I have my nurse manager here today, Rosanna. Could you actually hand her the mic and she can actually speak to that piece a little bit more about when we can do an ultrasound?
So we, once we do a pregnancy test and we verify that they're pregnant, as long as they're 6 weeks along or further, we can do an ultrasound. Oftentimes we can do it same day, depending on our scheduling, or if not, within a week's time of them coming in, we'll get them in. So that is, like Rita was saying earlier about women that are anxious, that have had miscarriages before, those kinds of things, them having that quickly gives them a lot of peace of mind going forward while they're waiting to get in to their doctor's office somewhere else.
Yes, and we only do an ultrasound to confirm pregnancy, so we're not, a lot of people may think that we're doing that to get a picture or to do something different, but our orders are for confirmation of pregnancy only. So just to kind of clarify that piece as well. And then I will leave it to Ryan to explain what's the answer, who's going to help us with this.
Who's responsible?
I have my own answer, but I'm sure Ryan has a good one. So,
Well, I think we're all responsible in a way if you work in healthcare leadership, right? As COIA, we have multiple responsibilities. We do have a clinic system, and so we do have, outpatient OB-GYN access that we are responsible for to provide, but we're also the largest hospital with the most deliveries, and so we do hold in very high view our responsibility for our community. Publicly elected board of directors, right? We are your hospital here to serve the community. So our highest priority right now, again, is making sure that we have quality, competent OB-GYN physicians in the hospital to deliver moms coming from whatever clinic system they're coming from, or unassigned moms that just never did get prenatal care for whatever reason that show up in our hospital actively laboring. That is our number one priority. Number two, of course, is recruiting physicians who want to work in the outpatient setting and midwives and get a program going there, because we do really see the need. Advanced practice providers, expanding the team-based physician-led care is a much more sustainable model. So, Graciela Soto, she's responsible for Altura, and she's done a great job recruiting and retaining OB-GYN physicians. We have Carrie Hydash and Chad Vodder of Family Health Network are responsible for their clinic network. And so we all have joint responsibility when it comes to our common mission of serving our community. And then that's Tulare County Health and Human Services certainly plays a big part of that. Tulare County Women, Infant, and Children WIC offices we work a lot with. So we do have some great collaborations happening. COEA, we were awarded a $1.2 million HRSA grant for rural care coordination for pregnant rural moms with a focus on farm worker moms. So we actually employ community health workers that go out into the fields, quadrilla events, and we go do home visits in the rural communities. We really try to, identify moms early on, get them connected with Dr. Carlos Rangel or Sabagal out in the rural clinics, and get that vital prenatal care going early on so we can identify high-risk issues and connect them to MFM if need be. And so we're working very hard, to meet the needs of the community. We just need to work harder, I guess, and find folks that want to run alongside us.
So, Rita, would you like to add anything to that about what needs to happen and what in your opinion, what's the thing that one big thing that needs to happen that's going to change either the number of providers that we're getting, or the connections that we're making, or what? Or this is just going to go on for a while?
Well, I think what COEA is doing, Ryan's been looking and looking and looking, maybe trying to, connect with some of the training programs, like, the midwifery services. And, sometimes they're restricted as to taking students to train. We have a good student nurse availability as far as COS and the other RN training. We have not been able to do midwifery services at COEA. It was a long time ago when I was with Dr. Levitan and Dr. McKee. We trained a couple of midwives, and those midwives unfortunately left, but we did train them. And at that time, we were able to. In the last several years, that has gone by the wayside. So I think we need to open that area up, because I think, especially if they're local, and we have several local midwives that are working in Bakersfield, working in Fresno, working in Clovis, and they live here. And so it would be good, I think, if we got them to establish when they're starting their practice, and they're more likely to stay.
Well, yeah, that does sound like an obvious solution. I know you've been waiting to ask a question, so go right ahead.
Brittany Rodriguez. I'm actually with Altura Centers for Health, Chief Nursing Officer. Graciela is currently on the live stream right now. So I just did want to speak on just the previous question regarding high risk and how that's identified, because it challenges the name of the game here. So we had to improvise workflows and to enable to identify these patients when calling in our current patients or new patients that would be coming to us. So we had to employ a new OB enrollment process for patients, because a lot of the times we will get late transfers, and to us that is beyond 14 weeks. And so for us, it's important to be able to identify any pre-existing conditions in past pregnancies, or even in the medical regarding their current health status. So what we have to do is we do full questionnaires on patients' previous histories, and then from there establish whether we would be able to take them on or refer care to either like our MFM or our high-risk pregnancies in the community. So partnering with other entities as well, it's been a struggle. We do have to providers are delivering at the facility or at COEA, but also seeing patients and they're really overworked, but they share the passion to be able to care for these patients. And it's truly heartbreaking for these providers as well to be able to limit their time to specific entities, and in such cases limit cap patients for certain periods of time to be able to deliver safely. So a lot of these partnerships are very much appreciated, and so I just wanted to make a comment on that. Thank you.
I want to ask something about. I know that there's a lot of discussion beyond OB care and GYN care about mental health situations generally in all populations. And I think Dana told me a statistic not too long back about a woman, a pregnant woman, under stress, like stressed out about her situation. She labors longer. Did I hear that? Like her labor is a lot longer than the average, unstressed woman who's unstressed having a baby. But what are the effects on a woman's mental health when she's concerned so much about her care? Or are there effects like that? Are you seeing that kind of an effect on a woman's health? Rita.
I definitely am seeing it. Yeah, well, the delay of care, it bothers them a lot. And then when they get in, they want this, and this done. And they're very concerned. How's my baby been developing? How am I doing? What's going on? And I am seeing a lot more postpartum depression, a lot more postpartum depression. And I think a lot of it is because they sort of are not really, a lot of them aren't really able to enjoy the whole labor or enjoy the whole pregnancy. They're worrying about this, they're worrying about that. Will my doctor go out? Will they be there? Will I be able to get enough care? And then, the delivery, however that goes, and then the follow-up isn't as good as it should be. We should be seeing postpartum women sooner, and they're 6, 7, 8 weeks out for postpartum care. The C-sections are seen in 1 or 2 weeks after, but it's a very minimal visit. We don't have the time to sit and say, hey, how are things going with you? I mean, I try my best, but I'm not, able to really spend that 30 minutes or whatever it is they need. So I do see that it is affecting, and it affects how they are able to relate to their children. I just saw a woman today. She has a 2-year-old and twins, and she is just up to there and just
barely hanging on. Huh?
Yeah, and she is, in tears. I don't feel like I'm doing enough. I don't have any help. What can I do? Where can I go? I need, to talk to someone. I need a counselor. It's hard to get in there also.
We have a question over here.
Oh, okay, go ahead.
Hi. So we got a good overview from Dr. Levitan about the education and training of OBGYNs, but my question is about midwives. How are they trained? What route do they follow? And is there a certification? I'm not sure how they fit into that part of the.
As a certified nurse midwife, you have to be an RN. And way back when I did it, you had to do a lot more, many, many years. But now it's a little bit easier. You go and then you can go from your RN, if you have a bachelor's degree, to get your CNM and get your master's degree at that time. So it's an extra 2 years after an RN. But most of the midwifery, you have to be an RN for at least 3 years prior to becoming the midwife.
Is there an equivalency to a residency for midwives?
They do have to do a certain amount of deliveries, and they have to be in labor and delivery with a supervising midwife or physician who, sponsors them during that time, yes.
So
Yes, we have to be certified nurse midwives. You have to be, yeah.
Okay, so does anyone have a question that hasn't been? Go ahead.
I do.
Oh, it's right there.
Okay, you first. So the mental health and the postpartum depression. Dana, can you kind of explain how Care Clinic offers postpartum help with mental health?
Yeah, actually, we do offer services in postpartum care and depression. And I actually, again, I have a nurse manager here who is really important in that role in meeting with those clients. So I'm going to let Rosanna kind of answer that question again, if I can, real quickly. Or if you can just talk really loud, Rosanna, and talk about that piece a little bit and kind of what you're seeing in that area, because we have seen an increase as well, Rita, in that area, and people calling for those services. And again, they are free, always to whoever comes in, but Rosanna can probably speak to that.
Yeah, so postpartum support is something that we've really been looking into and trying to increase availability for our clients, because a lot of times they just need somebody to talk to. Like Rita was saying, they go to the doctor's office, they don't have time because they're so busy to just sit and talk to them. And so that's what we offer, is they can come in and they can sit and talk with somebody. They can tell them, like, yes, this is normal, like your feelings are valid, and this is how it feels to be a mom. And we have tools we can offer them to encourage them and just give them that space to feel heard and seen, and to have somewhere to come to get out of the house. And it doesn't include babysitting, but we do encourage them to bring their babies. Everybody who comes to our clinic can bring their kids, can bring their babies. We don't make them find a babysitter for that.
Does anyone else have? Oh, okay. Right here. Unless she's closer.
So I'm just trying to. I'm a little frustrated to think about what we're dealing with in this county, and impressed by what you all are doing. I want to know a little bit about the broader context. Are we alone in this, or is this a valley issue, or is it a statewide? Is it national? Is it rural? What's the bigger context?
Yeah. So, and I have the stats here I shared earlier, but I'll share again. But no, we are sadly in very good company. So between 2010 and 2022. 537 hospitals discontinued obstetric care in the United States. 299 or 300 of those were urban, 238 were rural. So we are not alone in this across the United States. There are areas that are hit harder. There are some areas that have very low reproductive rates too, and so those aren't as impacted as much because there's just not as many babies being born. And so some of these rural hospitals, there's 39% of the counties in the United States do not have a single OB or midwife in the county. All the rural communities, of course. But so yes, sadly we're in good company, and fortunately we're not as bad off as some, but we are in a tough spot right now. We are taking action. We could have had OB hospitalists here this week. We are, however, very sensitive to our community OBs, and not wanting to isolate them or ostracize, or and so we've had multiple meetings. I meet at least weekly with OB hospitalist group leadership and physician recruitment. And I talk all the time with my OBs and the OB community, and we meet with our laborists. So our laborists agreed to extend, to give us time, and then we're flying out OB hospitalist group a week from next, and they're going to meet in person with our community OBs to talk about how they can come and help support, so that our OB community feels comfortable with the hospital contracting with the largest OB medical group in the world to bring OBs here that they're now going to work alongside, right? And so we know we are in a critical position, but we're trying to navigate this with ultimately the best outcome for our community, which means preserving our relationships with our local physicians, but also supporting them, because it is a mixed bag, I will tell you, right? So there's some OBs who are like, hey, we got this, I don't want other groups coming in, and, other ones like, no, I need the help. Like, I want that. I've worked with them. They're good, bring them. And so we're trying to, as best as we can, bring consensus and support from the physician community alongside folks like you in the community in general who are concerned. So,
Can you tell us something about the maternal mortality rates, the infant mortality rates, how our county compares to the state, the country, and are those going up, going down? What can you tell us about all of that? Huh? Oh, and globally, yes.
right. I don't have global stats, sorry. But I will tell you, I do have local and state and United States. So over the last 10 years, infant mortality rates in California has declined by 10%, almost 9%. So as of 2023, the U.S. infant mortality rate was 5.4 per thousand. Okay. California, 4.0 per thousand. 16 years prior in 2007, California average was 5.34. So we've decreased from 5.34 to 4.0 as of 2023. Tulare County in 2023 is 4.2, so it's slightly above the California average. And when you consider the percentage of high-risk pregnancies in this county, we're doing pretty darn good. Kauai Health was just recognized. Yeah, so she's got active moms in the hospital. You couldn't ask for a better. God bless you, Rita. Thank you.
Well, okay, perfect example.
Hero and a legend. I know so many people who have been delivered by Rita. So good news on the infant mortality front. I mean, no death is acceptable, but at the end of the day, we're doing better than the national average, and we're about the California average. I will say, there's 5,000 or so hospitals in the United States. Kauai was just recently recognized in the top 100 for maternal care. So that's rated on our health outcomes, our quality outcomes, and so
is that rated on volume?
No, it's not based on. Well, I think honestly, I don't know what all goes into the top U.S. World News Report ratings, but I know a lot of it's quality. So just know that you have a good hospital that does great care in maternal health. And we're always striving to be better. So that's infant mortality. And when you look for disparities, so population health is a big thing for me, and finding health disparities and then putting things in place to help mitigate or close those disparate gaps. Educational, for infant mortality, educational attainment and your payer, Medi-Cal. So you couple those two together, and that is a huge disparity in infant mortality in our community. So again, hiring community health workers, promotoras out in the community to really help address those social barriers a lot of time and access barriers to get those moms in sooner and help mitigate some of those disparities that we see. I don't have as good as news in terms of maternal mortality. And so, let's see here. No, the birth rates. Oh, maternal mortality. So the California average, this is per 100,000 moms, okay? So 21.6 maternal deaths per 100,000. Tulare County is 32.1. So
what's the U.S.?
I didn't have the U.S. on that one. I'm sorry.
What are they dying of?
Yeah, what's the cause?
Rita, I don't know, or maybe Dr. Levitan, you can speak to what are the more common causes of maternal mortality. I mean, pulmonary embolism, bleed, hemorrhage.
It's very uncommon at our hospital to have that happen. I think the most common reason would be postpartum hemorrhage, which is not rare, but obstetricians and the team at the maternity unit are trained very well to deal with that. They have drills on how to address postpartum hemorrhage. There's a condition called preeclampsia, which is high blood pressure emergency in pregnancy that can oftentimes result in maternal illness, but rarely death. There's something called the pulmonary amniotic fluid embolus, which occurs rarely. So I think probably the most common would be postpartum hemorrhage. But that's something that the hospital is trained to address and the physicians are trained to address.
But why more in Tulare County then?
We have a very high risk population, obesity, diabetes, hypertension. I don't know, Dean, you can speak more.
Oh yeah, I'm not sure what that absolute number is, but if it's per 100,000,
Yeah.
it takes
100,000.
20 years for Tulare County to have 100.
1.5 per year.
Yeah.
Yeah.
Yeah, so I'm not
Yeah.
sure if there could be, one maternal mortality may skew that in a way because we're not doing 100,000 delivery. It takes many years to do 100,000 deliveries here.
Yeah, that's good perspective. Thank you for that.
Okay, we've reached the end of the evening. I don't want anybody else to be running out, because they have something that. Did anybody have just a real brief final question? Go ahead. Oh, I was pointing to her. That's okay.
She hasn't had a question yet.
You know, flip for it?
If you don't mind.
I'm not in a hurry, so I can hang back.
Sorry. Okay. So I have a quick question, kind of dovetailing on what the gentleman said here. Politics always enters into something. And there's always unintended consequences by legislation done at both the state and federal level. I'm sure that you guys have identified the top 10 barriers to whatever it is that's causing irrational over-regulation. And so I hope, and this is more of a comment, and you can dovetail on it if you want to, I hope that you guys are working with elected leaders and people that can make the change that will free up the system to allow schools to graduate more OB/GYN than what they were 40 years ago. I think there's some common sense solutions to these over-magnified problems that are generally self-induced.
I was just curious what the situation is as far as contraception accessibility and use and availability, that sort of thing.
And we'll let that be our last question. Go ahead. Who wants to take that?
Yeah, well, I'm a clinical pharmacist by background, and so in terms of access to pharmaceutical contraceptive, oral contraceptive, or Depo-Provera, what have you, fairly ubiquitous and pretty low barrier as it relates to copay costs or what have you. So I think as it relates to access to contraceptive from the traditional sense, I'm not seeing a lot of barriers there.
Remember, our discussion this evening is about how to have babies. How to not have babies.
Okay, yeah, all right. So thank you so much, everyone, for coming and putting up with me tonight instead of Paul. And I hope it was very illuminating. It was very illuminating for all of us.
Really, thank you for having us. And Graciela Soto and Altura, thank you. 3 of our 5 laborists are Altura OB/GYN physicians, so thank Altura for their support for your community. Thank our board of directors, so Dave Francis, Mike Olmos, and Dean Levitan, your publicly elected board. 3 of the 5 are here tonight. Deborah Volison, our director of patient experience and community experience too, so just thanks to the Kuya Health folks for coming out and supporting the community.
Thank you all very much. Thank you very much, Melinda Morales, for moderating tonight. It's very well done. Give her a hand. Welcome relief from me. Next month here at Tulare County Voices at 2:10, we will be having an interesting discussion. How many of you heard this thing called Facebook? Anybody use it, go on it, provide information, that, or Instagram? How many of you heard of the Visalia Stringer, or the Visalia Watchdog? Our program next week will be Meet the Visalia Stringer. News gathering in the social media age. April 8th, we hope to see you there. Thank you.
Hey, thank you. Actually, one of my children, my son who's 27 now, so he's going strong. Hi.
Thank you so